we're going to move along to our next section, Palpitations and Arrhythmias by Dr. Alex Thompson. And I know Dr. Horner introduced you earlier. So you grew up in Grand Forks, went to undergrad and med school at UND, did residency and fellowship at Mayo Clinic, and you have been at Sanford and Fargo since September of 2019 with outreach clinics as well. So thank you so much for coming and speaking with us today, and we're excited to hear from you.
Yes, thank you for having me. I'm excited to be here, and like you said, everything was right. I grew up in Grand Forks and made it all the way down here to Fargo. So I'll be talking to you today briefly about palpitations and arrhythmias. Very common complaint that we see, that I'm sure a lot of you see in your clinics as well as we do. So feel free to ask any questions at the end here. I have no relevant financial disclosures. So what we're going to talk today about really is more in the outpatient setting. First, identifying those concerning signs and symptoms in patients with palpitations for underlying arrhythmia or other concerns. We're going to recognize the need for testing and which tests are highest yield in patients with palpitations. So we'll go through that pretty well. And then we'll also talk a little bit about the basic management of patients with arrhythmias, including cardiac ablation. I won't go into depth about that, but just knowing what treatments are out there and what we're kind of thinking about when we're seeing these patients. I'm going to start with 3 questions, and I'll go through the, I'm not going to do the answers right now, but at the end I'll talk about the answers. So true or false, finding of sinus arrhythmia on ECG in children and adolescents is abnormal and requires further testing or investigation. So you can think about it as we're going through this. Second one, you are seeing a 15-year-old male who complains that it feels like his heart beats so fast that he cannot count it, lasts 4 to 5 minutes, and then suddenly goes back to normal. This occurs once or twice a month. What is the best test that you would use to identify if he is having arrhythmia with these events? ECG, 24-hour Holter, a 30-day event monitor, or an EP study? And then the last question, which finding, and we'll talk about this, all these things through the talk, which finding is least concerning for a true arrhythmia in a patient with palpitations? Is it a patient with a grandfather with a heart attack at age 58, patient with WPW on baseline ECG, an older brother with diabetic cardiomyopathy at age 33, palpitations that are associated with syncope, or a sudden onset and resolution of tachycardia? All right, so palpitations. Palpitations are really a perceived abnormality of the cardiac rhythm, and so palpitations could signify something that the heart is actually doing, or it could just be a feeling that the patient has. And it's very common in children. I'm sure you see it a lot. It's often benign, but obviously we don't want to miss those cases where it's not. Patients are usually asymptomatic between the episodes, and that's what makes, as you can tell, a lot of these topics, history is so important when you're evaluating these patients. So what to ask for in the history? Well, there's a lot of things. You want to ask them to really describe the episodes. How often do they happen? This will help, first of all, know how annoying it is or how much it's bothering the patient, how persistent it is, but also will help you when you're thinking about testing the patient to figure out if this is an abnormal rhythm causing these palpitations. How fast is it going? And I find this is a specifically difficult question for different reasons in younger and older kids. It's often difficult for, obviously, younger kids have a tough time answering it, especially the 5-6-year-olds. Teenagers have a tough time answering anything, really, in general. But it's often tough to get a good answer. But really, what I like to ask is it so fast that it'd be difficult to count it? And over 200 beats per minute is concerning. That, of course, is dependent on age. A newborn with 200 beats per minute isn't as concerning as a 17-year-old. And oftentimes you'll have patients whose mom is a nurse and takes their pulse. So sometimes it's kind of interesting. Apple Watches are becoming big. So any symptoms, and then any symptoms that happen during these episodes. So lightheadedness, vision changes, definitely syncope. It's more concerning if it's associated with these symptoms or specifically syncope. Now, it can be difficult to tease that out because sometimes people will stand up, they'll get lightheaded, and they'll pass out, and they feel like their heart was going fast when they stand up, which could be orthostatic. It's more concerning if the tachycardia is what occurs first. So that's, yeah, exactly what I talked about. And then associated with exercise, that is a more concerning thing as well. Just like chest pain, palpitations with exercise can tell us that maybe they're having arrhythmia with exercise, and there can be some dangerous arrhythmias that are associated with exercise. So exercise and palpitations and syncope are very concerning. And this can often be difficult to determine, because if you ask a 5-year-old if they get a fast heart rate, they'll say, yeah, every time I run, my heart goes really fast, which can be a normal response. So it's kind of tough to tease that out sometimes, but it's very important. All right, other important things to ask, definitely personal history of heart disease. So congenital heart disease, Kawasaki's, myocarditis, and then MIS-C is a big one that is obviously newer to our world now, but we're seeing it not uncommonly. And these patients often do have kind of tachycardia or palpitations after the initial episode, so it's important. I'm sure Dr. Trev will talk more about that, but important to kind of keep that in mind. And then pertinent family history. So if you have a patient who has a close family relative who's had sudden death, cardiomyopathy or arrhythmia before 50, that is more concerning. And it's important to ask about all causes of sudden death, including car accidents and drownings. Sometimes people won't think about that, but if it's a single just driver, single car accident, you know, there's a concern that it was an arrhythmia that caused them to crash, or a drowning as well. All right, so physical exam is usually normal in patients with palpitations. It's very rare that you'll actually get the palpitations when you're listening to them. But if it is abnormal, it's more concern for a true arrhythmia, and really you'd be concerned about some underlying heart problem, congenital heart disease, myocarditis, other things like that. So testing. Baseline ECG is good in anybody with palpitations, can show some baseline abnormalities. You can pick up WPW on that. You can sometimes see if there's any chamber enlargement or hypertrophy, and then also can see some T-wave abnormalities if you're concerned about some sort of pericardial or myocardial inflammation. Now, normal ECG does not rule out an arrhythmia associated with palpitations, so it's good to know. Echocardiograms are generally not indicated unless there's concern for underlying cardiac disease. So concerning history, positive family history, an abnormal physical exam, or concerning ECG findings. So this is also mentioned in that AUC criteria. It goes through chest pain, also talks about murmurs and palpitations and other things. So we can get that, we can get a copy of that sent out to everyone. Exercise stress ECG. So often if there's palpitations with exercise, we will have patients do a stress ECG just to make sure they don't have any arrhythmias that come out when they exercise. And then cardiac monitors really are the mainstay of trying to figure out what the palpitations are and if it's a true arrhythmia. So I'll go through those a little bit, the different kinds. There's a lot of different cardiac monitors out there. Holter monitor, generally 24 to 48 hours, and patients wear these continuously. They can record their symptoms in a journal, and then that helps us to correlate with the rhythm that occurs during those symptoms. The benefits of Holter monitors really continuously recording the rhythm. So for those 24 to 48 hours, you can determine a burden of extrasystole. So PACs and PVCs, you can really get the percentage of heartbeats that happens in that time period. They can detect occult arrhythmia. So sometimes, especially in patients who have had myocarditis or MIS-C, we often do these Holter monitors and follow up just to make sure we're not missing anything, or other congenital heart disease. And then these are really best for people who have palpitations every day or every other day, where they're more frequent, where you're more likely to catch these episodes. There are some monitors that are similar that can be worn for up to 2 weeks, so those can be helpful as well. 30-day event monitors are also helpful, and these are more helpful for less frequent palpitations. So there's many different types. Some have electrodes attached to the chest, kind of like Holter monitors. There's other ones that can be pressed against the chest during symptoms. Most need to be triggered, although there are some that do have auto trigger, or with certain heart rates they'll trigger. But the main thing is a lot of these have to be triggered. by the patient when they're getting symptoms. So again, these are better for less frequent arrhythmias, kind of weekly to monthly arrhythmias. They're worse for shorter arrhythmias because the patient usually has to trigger them. So anything that lasts for under 3 minutes is a little bit tougher. But again, some are auto-triggered and some actually do have a memory loop. So they can, when you trigger them, they can actually go back for a minute or two. Those can be helpful. And then again, these are harder for small children to use. As you imagine, they just don't notice their symptoms as much or forget to push a button. Implantable loop recorders, just so you're aware of them, they can be used. It's continuously recorded for up to 3 years. And these are implanted subcutaneously, usually in the left peristernal area of the chest, but they can do them in different places as well. The good thing about these loop recorders, first of all, they last a long time, and they can be, the episodes can be transmitted, so you don't have to wait 3 years to get results of your loop recorder. A lot of those cardiac monitors can actually do transmission as well. And then these are better for patients where non-invasive monitoring is not helpful and they're having very infrequent but symptomatic episodes and they're trying to figure out what's going on. Then EP study can be done, which is an invasive study performed in the cath lab where they use catheters go in the heart with electrodes and map out the conduction system of the heart. I won't talk about this in depth, but this can be done. And a lot of times when we do this, it's in conjunction with an ablation for an arrhythmia that we're already suspecting. So I will briefly talk about the types of rhythms that we can see. Sinus tachycardia, very common, almost always secondary to a non-cardiac cause. So orthostatic patients, when they stand up, they get tachycardic. Dehydration, anxiety, exercise, fever, there's a lot of different causes. Very rarely is it an intrinsic cardiac problem. Sinus arrhythmia is very common in pediatrics, indicative of increased vagal tone. So you'll definitely see it in younger kids, a lot of old kids, especially athletes. And really you get this increased rate with inspiration and decrease with expiration. So you can see it's a little bit subtle in that strip down there, but definitely present. Premature atrial contractions, again, very common. Pretty much every Holter that we see has a few of these on it at least. It's actually kind of rare to get no PACs, but usually not very frequent. They're often asymptomatic, but people can feel kind of an extra skip beat. Very rarely require treatment, and it's an early beat arising from atrial tissue separate from the SA node. So you'll often see, Dr. Canada did a nice job going through reading EKGs, but you'll often see the P wave will be in a different axis, kind of in the middle of that strip, and an early beat there. PVCs, again, very common in pediatrics. We see these often on Holter monitors. Usually they're pretty rare or infrequent. They're often asymptomatic, but can be felt as skip beats as well. Rarely do they require therapy, although a little bit more common than PACs. They should be followed if their PVC burden is over 10%. Should be followed longitudinally, and there have been reports of tachycardia-induced cardiomyopathy where their function can actually decrease if their burden is over 20%. So those are often need to be treated or can sometimes be ablated as well. But obviously you'll be speaking with the cardiologist there. More concerning PVCs are anything that increase with exercise, where there's at least 3 in a row and where there's different morphologies. So you're seeing where it's coming from different areas of the ventricle. It's a little more concern there. And there's a picture of a PVC down there without the preceding P wave, and it's a wide QRS. Supraventricular tachycardia, or SVT, is the most common abnormal mechanism of tachycardia in children, and there's many different types, and I won't go in depth, but there's a reentrant type, which is the most common, about 90% of SVT in kids, AV reentrant or AV nodal reentrant. Both of them are a circuit or a reentrant tachycardia. And then there's an abnormal focus tachycardia as well, like an ectapic atrial tachycardia, which is rare, but is in pediatrics. So common characteristics, usually these start and stop in one beat. So kind of like a light switch turns on, all of a sudden your heart rate's going fast, turn it off, and it's back to normal. Usually these last some time. It's not like a I felt like my heart was going fast for 2 seconds. Usually it's a longer period of time. Heart rate is often over 220, but in older kids can be over 180. There's actually slower arrhythmias too. These occur without preceding symptoms. So a lot of times with people who are kind of vasovagal, they'll get these symptoms, feel like something's going on. After they stand up, then their heart rate will go fast. But these often happen where the tachycardia starts, and then sometimes they'll get symptoms, and then terminates with vagal maneuvers. So people learn that coughing or valsalving can often help them if they haven't been diagnosed with SVT. They can have a wide QRS, so it's important just to know that there can be some aberrant conduction, which is really usually a bundle branch block, or antidromic ADRT, which is WPW, with the tachycardia going in the opposite way of the circuit that it normally goes. So that can make it go wide, where it goes down the pathway. Again, there can be slower SVTs. PGRT is one of the common, more slower, more incessant. It's a permanent junctional reciprocating tachycardia, so that can be more in the mid 100s. And then with recommended SVT, echocardiogram is recommended due to there is association with congenital heart disease. Also, if this has been going on for a while, this can affect the function of the heart. I'll talk about Wolff, Parkinson, and White briefly, defined by 3 things: a short PR interval, slurring of the upstroke of the QRS, and then QRS duration longer than normal for age, which is important because it can be quite narrow for babies. This is actually a baby ECG here in the bottom. It does show some kind of subtle upslurring, but there is definitely upslurring of the QRS and widening compared to what you would normally see for that age. This is caused by an abnormal pathway connecting the atria and the ventricular myocardium. Normally, there should be nothing going from the atria to the ventricle other than the AV node. Other findings in WPW that can help to diagnose left axis deviation and absence of Q wave and P6. These patients are at risk of an AV reentry tachycardia because of the extra pathway that they have. There is a very low incidence of sudden cardiac death, but there have been reports of cardiac death and thought to be due to atrial fibrillation, which conducts through the pathway and causes ventricular fibrillation. Our AV node is good in that at a higher rate, it will block certain conduction through, but those pathways don't always block that, so you often get fast conduction with ventricular myocardium. And then WPW is occasionally associated with congenital heart disease. It's higher in Epstein's anomaly, up to 25–30%, but can be seen in CCTGA as well as hypertrophic cardiomyopathy. All right, so management of SVT, there's a lot of different things that we do, but it really depends on the type of SVT. Again, SVT is rarely life-threatening, although if it's incessant, it can cause some decreased function and tachycardia-induced cardiomyopathy. Really important to educate family on vagal maneuvers. So age-appropriate vagal maneuvers, cold ice to the face, especially for babies, and you're going to want to make sure you put some water in the bag of ice as well, so it's not just a hard bag of ice, and really cover their eyes and nasal bridge. Blowing through a straw can be helpful, especially for toddlers or younger kids. And then Valsalva, and I've had patients who have handstands with them. And then instruct patients to go to the emergency department lasting 20–30 minutes. Getting an ECG while in the rhythm is extremely helpful, and getting an ECG while the rhythm breaks, either that with vagal maneuvers or adenosine, is extremely helpful for us and for the electrophysiologists who are trying to figure out exactly what's going on and how to treat this best. Medications obviously can be used. Beta blocker, calcium channel blockers are kind of the first line therapy. And then in patients where there's a pathway or these reentrants, or actually most types can be ablated, and it's essentially a cure for the patient. So where medications can be helpful, it's more of a band-aid, where ablations can be a cure for the patient, so they can get rid of that abnormal mechanism. And then VT, this is a wide complex tachycardia with no P wave preceding it. Sometimes can be difficult to to differentiate between SVT with aberrancy. Really, 3 or more PVCs that occur in a row are considered non-sustained ventricular tachycardia, but they must be over 120 beats per minute or 10 to 20% greater than the underlying sinus rate. If not, it's considered an accelerated interventricular rhythm. Generally, that is benign and doesn't need treatment, but is recommended to have regular follow-up for that. VT is a lot more rare in pediatrics, approximate incidence of 1 per 100,000 child years, but it does occur, so it's important to keep it in your mind. Approximately 3% of healthy teenagers will have short episodes of VT and ambulatory monitoring, so you get a Holter in a kid where their symptoms correlate with their normal sinus rhythm, but then they'll have this 5-beat run of non-sustained VT. So what do you do with that? Factors that can convey higher risk really for VT are underlying heart disease, the rate of tachycardia. So the faster the VT, the more concerning it is. If you have symptoms with the ventricular tachycardia, and then again, if it worsens with exercise. Underlying causes can be due to congenital heart disease, definitely cardiomyopathy, or myocarditis, also secondary to MIS-C, or channelopathies, other things. Benign VT there is a diagnosis of benign VT, but you must rule out other causes. These patients will normally have ECG, echocardiogram, and Holter, and often will have exercise tests and cardiac MRIs as well. Treatment of VTs really depend on the cause and symptoms. No treatment is needed in a lot of cases. Reversible causes such as myocarditis, where it resolves. Electrolyte disturbances, where you can just replete the electrolytes, or neonatal VT, which is seen sometimes and often will resolve on its own. We can use medications. Sometimes with these short non-sustained VT, we'll use beta blockers, but it really depends on the type. And then ablation can be used for VT as well. It's easier to do that with a single focus as compared to multiple foci. And then ICDs can be used as well, especially in patients with underlying cardiomyopathy or channelopathy. All right, so that was a lot of information. Here's a little summary. Palpitations are common in pediatrics, and history is really the most important thing you're going to do. And then documenting arrhythmia on tracing is very helpful for treatment. Sinus tachycardia, almost always non-cardiac in cause. Extrasystoles are usually benign, but a high burden of specifically PVCs can cause a decreased function, so it's important to look for that. SVT, again, is usually non-life-threatening, but can be, medications or ablation are usually used there. And then VT, usually benign if no underlying heart issues, but it all depends on persistence and rate and all those things. So more investigation is definitely needed in a patient with VT. All right, so I go back to the questions. We can do them quick here. Sinus arrhythmia, is it abnormal? Do you have to do anything about it? No, you do not. Sinus arrhythmia, very common in pediatrics. I talked about that. All right, so 15-year-old, this lasts about 4 to 5 minutes, suddenly goes fast and suddenly goes back to normal. So kind of that fast onset and offset. What is the best test for this patient? So this happens twice a month. So really a 30-day event monitor is going to be probably the best for catching it, unless you're really lucky on a 24-hour Holter monitor. An ECG would be appropriate to get in this patient, but wouldn't necessarily identify the reason he's having the arrhythmia. Unless you found WW, that would be thought. And then what is the least concerning finding for a true arrhythmia in a patient? So the answer is the grandfather with MI at 68, older, person who's older who has other reasons to have MI. Whenever you have WPW in a patient, there's more concern about an arrhythmia, cardiomyopathy in the family, anything associated with syncope and sudden onset and offset. All right, so that's my discussion. I'd be happy to take any questions.
Thanks so much for your presentation, Dr. Thompson. That was a great review. For all of the past 2 presentations, the constant theme is the same as the constant theme from medical school. History, 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 right? Like, 75%, 70% of diagnoses for anything, not cardiac diagnoses, come from taking a really thorough history.